Get started. We'll get to the next slide. I want to thank everyone for joining us for tonight's PRS Grand Rounds. We're going to get started with the lecture and we'll have a Q&A after that, but just a few quick housekeeping tips beforehand. A reminder that you can read all of the articles associated with this lecture for free. The classic PRS articles online. They're available just on the homepage. Look for the PRS Grand Rounds logo. Next slide. And we also really want to thank all of you, our current participants, our past participants, our discussants, for helping us win several national awards for PRS Grand Rounds. And all these prior lectures have been archived, including the Q&As, the videos, and their article collections, and you can find all of these on prsjournal.com as well. Next slide. With regards to tonight, please remember to post your questions in the comment section. You can do this throughout the lecture. It doesn't have to be only in the Q&A. And afterwards, we'll go through all these questions and pick as many as we can for Dr. Patel to answer. And also, as we usually try and remind you all, please try and keep the questions brief, just because that way we can all see them on the screen and it makes things a little bit easier. So tonight we have the honor of being joined by Dr. Ketan Patel. Dr. Patel is an associate professor of clinical surgery in the Division of Plastic and Reconstructive Surgery at the University of Southern California. He completed his residency training at the Georgetown University School of Medicine and then went on to complete a fellowship in microsurgery at Chang Gung Memorial Hospital in Taiwan. Dr. Patel specializes in many things in reconstructive microsurgery with a focus on breast and extremity reconstruction, as well as the surgical treatment of lymphedema, on which he has co-written the benchmark textbook. And today he is going to be talking to us about microsurgery and supermicrosurgery in lymphedema treatment.
I appreciate the introduction, and thanks PRS for organizing such a wonderful forum to share information around, ideally around the world. And when I spoke to them about the folks that will be here listening, and I think the interest was on lymphedema treatment, I thought really to gain excitement and to kind of, for folks who haven't been introduced to lymphedema, to kind of understand what types of options exist and have existed for a long time, but now exist in the more contemporary literature as well as in practice. And so we're going to go over some of those, and hopefully it'll stir some discussions for folks to ask questions. There's a couple textbooks that we've put together with our co-editors, and several of the authors are from around the world that do these surgeries. And so a lot of the pictures during this talk are from these textbooks. So to understand a little bit about lymphedema microsurgery in particular, you kind of have to understand the evolution of microsurgery. And if you really look at it, here is just some kind of more sentinel events, but really one of the godfathers, or the godfather of microsurgery, is Dr. Bunke. Started exploring using microsurgery in the upper extremity in the 60s. And really from there, it became quite a spread of knowledge around the world in academic meetings, people sharing techniques and knowledge. And really it started to evolve even further, instead of just repairing vessels, but transferring tissue from different parts of the body and really transplanting them and understanding where the blood vessels are in relationship to skin and muscle and things like that. And so really from the 80s and through the 90s, it was really the evolution of understanding flap surgery. Dr. Kashima is credited as being the father of really supermicrosurgery and a lot of lymphatic surgery, and he has contributed significant to the understanding of perforator flaps and defining what supermicrosurgery is, which essentially is defined as manipulating blood vessels that are well under a millimeter in size. And really, that coincided with, from the 2000s to current, really technology improvements in our way we image the lymphatic system and the types of equipment we're able to use, and really has allowed the spread of the surgical techniques that we'll touch on for lymphedema, and really understanding a lot more about it, as opposed to kind of somewhat guessing about what's going on. And really, it's interesting, and just in the last maybe 10, 15 years, it's caught a lot of traction around the United States, the rest of the world for sure. But if you look at this textbook by some of the fathers of plastic surgery, Dr. Gillies and Millard, called The Principles and Art of Plastic Surgery, chapter 10 is on lymphedema. And even at that time, they used concepts that we now use. And Dr. Gillies utilized the waltzing flap as a way to transfer tissue with lymphatic structures in there to help with lymphedema. He termed it the lymphatic wick. And obviously, with the evolution of microsurgery, we were able to take that same tissue as a free tissue transfer and call it a lymph node transplant. But for the most part, these techniques were somewhat described back then. And you can see they were having fairly good outcomes in reducing limb girth and size by using these concepts of waltzing flap and transferring tissue with healthy lymphatics to areas that don't have healthy lymphatic tissue. And so to get into the surgery component to it a little more specifically, you have to understand a little bit about the staging. So the International Society of Lymphology has this widely adopted staging criteria, 0 to 3, which is really able to be discussed between providers, whether it be physical therapists or even patients. But really, when we start thinking about surgical concepts, we start breaking the phenotype into its components. And so early lymphedema tends to be dominated by fluid, and later lymphedema or mid-stage lymphedema tends to be more of a fluid/fat and fibrotic tissue. And obviously late-stage lymphedema, when the lymphatic system is completely shut down, is more dominated by fat and fibrotic tissue and less so fluid. And so when we think about our surgical concepts, we can kind of break it into those different components to lymphedema. One is excessive fluid shunting, one is removing extra fat and extra skin. And really, in 2021, for the most part, we have these different surgeries that we can offer. So we take those different components and apply them to these different surgeries: lymphovenous bypass, lymph node transplant or lymph node transfer, liposuction, and then the Charles procedure, or a direct excision of skin and fibrotic tissue. You can see that the progression of surgeries, for the most part, falls along this pathway. Earlier stages that are dominated by fluid, we do surgery that helps to address the fluid with shunting fluid from the lymphatic system into the venous system, and or transferring healthy lymphatics to an area that is void of healthy drainage. And as we get more advanced, we have to use more reductive type procedures like liposuction or direct excision. So when we think about surgery, you have to kind of step back and think, what are we actually trying to accomplish? And I would say in the snapshot in time, and particularly in the academic exercises, the limb circumference tends to be very important, limb volume and circumference, because that's what shows if there's a benefit or not. If something went from big to small, you've done something. But I will tell you that there are quite a few more patient-related concerns. A significant number of patients have cellulitis attacks that come frequently. This lends them into the hospital with IV antibiotics for several days. It takes them out of their daily routine. Obviously, limb heaviness goes with limb circumference, but garment dependence, especially in areas of warm weather where it can be very hot and uncomfortable to wear these tight garments that are quite thick. And overall, with all of these combined, we're really trying to improve the quality of life of patients, because at the end of the day, many of the surgeries we provide are really trying to enhance those quality of life. They're not necessarily life-saving procedures, but really life-enhancing procedures. And so when we go back to those components and talk more specifically about the surgery, so when we have patients that have more of a fluid dominant, maybe earlier, maybe mid-stage lymphedema, we can start thinking about what's called a lymphovenous bypass. And the reason I put this lymphoscintigraphy with intact lymphatic channels, lymphoscintigraphy is a nuclear medicine scan that really helps us to get a very generic picture of how the lymphatic system is flowing. In a given extremity, if you inject in between toes or fingers, that dye should manage to go to regional lymph node basins in 30 to 45 minutes. If it takes much longer, there might be a lymphatic transport insufficiency or delay. If there's no flow, then you have a bit more of an advanced lymphedema. And so in those patients that don't have more of the advanced, but kind of the earlier and mid-stage lymphedema where the lymphatic system is slow, but it is working, we can offer lymphovenous bypass, meaning we can take the lymphatic system and transfer the fluid into the venous system. And before talking about it, you have to understand a little bit about the events that occur. So an upstream obstruction of the lymphatic system leads to some characteristic changes. One, that the vessel has a pressure increase. And just like every other vessel system in the body, there is a compensatory series of events. It dilates. Because of the dilation, there's hypertrophy to try to decrease that dilation with eventual luminal obliteration that occurs when that upstream obstruction is not relieved. And when we, this is a study out of Japan, and when we look at a given individual with either early, which is represented here on the left side of this histogram, to diffuse, which is more later stage, you can see that the propagation or the progression of the disease within an actual lymphatic vessel is heterogeneous within an individual patient. Meaning earlier stage lymphedema will have still normal, which is represented in green, some abnormal lymphatics, and as we move forward, the proportion of abnormal and severely sclerotic lymphatics becomes more. And so what we do is in this surgery, we take an incompetent lymphatic vessel that doesn't have much proximal flow and has stagnant fluid, and we connect that to a unidirectional, ideally unidirectional venule that's underneath the skin. We have several different configurations that exist. In order to do the surgery, you have to understand where the lymphatics exist. And so you can see that if you look a cross-section of the skin, in this top portion, the skin, and this deeper portion, the muscle, that subdermal lymphatics exist up in the epiphyseal compartment, which is above the scarpa plane. We have slightly deeper lymphatics here, and then we have submuscular, intramuscular lymphatics that exist deep to the fascia. And you can see that these lymphatics actually travel along the superficial veins, and it intuitively makes sense because the lymphatic system is actually a product in the embryo development of the cardinal vein and of the veins. And its function actually is very similar to the veins. And so it's no surprise that these lymphatic structures, if you look closely, exist. The blue being the veins within a cross section of the arm, and the green being the lymphatics. They exist within roughly the same area. And this is indocyanine green, which really is what I highlighted about the imaging technology that has helped improve, really show us where these superficial lymphatics exist. And you can see with an injection either between the toes here on the right or between the fingers on the left side, you can see that these lymphatic structures exist on the leg here on the medial column, kind of where the saphenous vein travels, or on the medial aspect of the forearm, kind of where the cephalic vein travels as well. And so this gives us an idea that we can utilize this imaging plus our surgical techniques to help manipulate the system. And when we talk about connecting the lymphatics to the veins, there's several different configurations, which I won't go too deeply into, but end-to-end configurations, side-to-end configurations, double end-to-side, and side-to-side, and end-to-side, which really is one of my favorites to allow for the lymphatic fluid to drain into a vein and ideally utilizing some of the effect and the pressure gradient that's developed by flow within the vein. And so really lymphovenous bypass is, for the most part, better in earlier stage or grade disease, and you do need lymphatics with some structure in order to sew them, and ideally no vein disease in the extremity. And so when we inject indocyanine green, this is an upper extremity, you can see, you can see that the dye travels along the lymphatics, and you can mark these structures out. It's very important to be able to identify these before placing incisions, otherwise there'll be several incisions everywhere and kind of a blind looking for these vessels. And so where we mark these incisions, and sometimes you can see the superficial veins represented here in blue, and usually where they cross, we can make a small incision You can use lymphozurin blue to directly see the lymphatics, and you can see a neighboring vein and lymphatic. And in this case, the vein is somewhat larger than the lymphatic, so you do an end-to-side anastomosis using 12-0 suture here in an interrupted fashion. And you can see that once we release the clamps of the lymphatic, which has the black bulldog on it, it allows us to get good flow, and you can directly visualize that flow from the lymphatic into the vein, knowing that this is not only a patent but a strong anastomosis as well. So this is an example of a patient that's had the procedure. Usually several anastomosis may take 2, maybe 3 or so hours to do. And you can see that lymphozurin blue is injected before making the incision, so we can directly visualize that lymphatic before we manipulate it. And this is that same patient, just one clinical example of this. Bladder cancer. He had a pelvic lymph node dissection and radiation, has significant suprapubic fullness, but also you can see by his measurements, and if you look pre and post, on the left side, he had a 5 centimeter difference at the level of the ankle, which is highlighted here. You can see is a significant difference. And after 5 bypass surgeries, he's able to achieve essentially a normalized ankle. Slight difference still up top here, but there is some fatty changes up in the thigh. But one of the most important part, which I highlighted before, is the quality of life implications. This gentleman doesn't have a pump and doesn't use compression. He's an electrical worker working outside in Southern California, where it's quite burdensome for him to wear a garment on his entire left lower extremity. So going back to the next microsurgical type of procedure that we're able to perform for these folks that do still have a fluid component to their lymphedema, and at least in my practice, for those folks who essentially are not really good candidates for bypass procedures, i.e. that their Lymphocyntigraphy, which is kind of a screening exam, doesn't really have any intact channels noted, and that's when we move to a lymph node transfer. And so what essentially that is, and this is a cartoon from my mentor, Mingwei Cheng out of Taiwan, we take physiologically active lymph nodes, we power it with an artery and a vein connection, and allow the soft tissues to heal within a lymphodematous area. And because of those connections, we're able to get some essentially absorption of that lymphatic fluid centrally. To understand how that actually works, because in some ways it sounds a little magical, but if you understand the architecture of the lymph node, you'll understand why it works, is that there are afferent, efferent lymphatic vessels to the lymph node, but there is actually a blood circulation to each lymph node. And there are connections, lymphovenous connections at the level of the lymph nodes that's actually responsible for lymphatic flow throughout the body. And some studies estimate it's 50% of the centralization of lymphatic fluid occurs at the level of the lymph node. So two thoughts that occur is lymphatic regeneration, that those afferent, efferent lymphatic vessels will kind of reestablish themselves, just like they would if you were to cut skin and sew skin together. They will find a way to reconnect. And also the other concept is using those nodal blood circulation or those intrinsic lymphovenous shunting to help provide flow from the lymphedema side to the actual flap. We have several different sites where we can take flaps from. That's represented here in the kind of more orange side. Most common described are from the groin, the supraclavicular region, axillary region, omentum, and from other parts of the submental or cervical region. And in a given extremity, we can place them essentially anywhere within the extremity, surgeon's preference where that may be, whether distal or even proximal. Common one used, at least in my practice, is the groin lymph node transfer. And over the years, we've got a very good understanding about the anatomy of this region and that there are superficial chains that drain the lower abdomen so they aren't affecting the lower extremity drainage. We use a concept called reverse mapping to help us identify some lymph nodes and preserve others. And we also use imaging to help us pre-plan for these lymph node transfers to make sure we know where those lymph nodes are in relationship to the blood vessel. So here's an example, a patient with a volume differential of 2 liters, breast cancer-related lymphedema, previous pedicle tram some number of years ago. DLA is essentially infections, so this patient has several infections and has swelling in the hand. So what we're able to do is take tissue from the groin. This is essentially what a packet of tissue is. And if I had a ruler there, it would be about 7 centimeters or so. This is somewhat of a distal transfer on the ulnar aspect of the forearm. You can see it placed here. Microsurgery is involved with artery and vein connection to power that, to power the flow in through the lymphatic tissue. And you can see, if you give it enough time, you can see that there's a significant difference in this extremity as it was in the previous picture. A lot of wrinkling noted. You can see the hand is decompressed, and significant improvement. And we got off about 800 cc's of volume. The rest of the volume in this patient I didn't include for the brevity of the talk, is we use liposuction technique in the arm to remove that fibrofatty tissue, which really helps normalize the extremity. So lymph node transfer is very good for pretty much any stage of disease. Again, there's some surgeon preference to that. We use proximal distal transfers. You don't really need intact lymphatics. As I said, it's an artery and veins connections. And so really the microsurgery and supermicrosurgical component and treatment of lymphedema can really help reduce symptoms of lymphedema. And it's really, we can thank obviously a lot of the pioneers within the specialty, but also the advances in technology over the years. Not only imaging, but also microscopes and the actual instrumentation. And so, further applications of microsurgery will likely continue to add lymphedema treatment. We're still on the cusp of this specialty, and it's going to continue to grow as young people learn to do this and use their own innovative skills to come up with new ideas. Thank you very much.
Great. Thank you so much, Dr. Patel. It was a fantastic and very comprehensive lecture. I think soon we'll move on, but just one more quick reminder that all of the collections for this lecture, as well as the prior Grand Rounds lectures, are free on prsjournal.com. And if you just go there and look for this same PRS Grand Rounds logo, you will find them there. And with that, we are going to go ahead and move on to the Q&A portion of PRS Grand Rounds. If you can, please keep your questions brief as you're typing them into the comments, or you can separate them if you have other comments, just because that allows us to go ahead and put things on the screen so that everyone can see. So we'll go ahead and get started. Our first question is coming from Saeed Azuri, one of our other resident ambassadors. I says, thanks very much, Dr. Patel, for joining us. It seems like there are a lot of different programs looking for microsurgeons that have an interest in building lymphedema programs or lymphedema centers. Do you have any pearls or tips for those of us interested in creating or kind of starting an efficient and effective program from your experience?
Yeah, that's a great question, and I think there's several different avenues, and I had to do that 7-8 years ago when I came here to USC, and it's several fold. I have a whole lecture about developing a program related to lymphedema, but it involves forming a team. Definitely having a team approach. You need good therapists. You need other medical professionals such as vascular surgeons, internists, obviously your allied health professionals to be involved, and really, hopefully utilizing your training and what's available to give. I personally gave lectures to various therapy groups. I also was involved in some of the centers of excellence designation criteria, and so I wasn't actively involved in a lot of that part of the development, but it does take more than one person for sure, and for the first several years at going somewhere where that doesn't exist, it's going to take some effort, and really it is kind of more of a sophisticated form of marketing, really meeting, handshakes with folks, explaining what you're able to do and how you can work together with therapists. It's really important.
Great. Thanks, Dr. Patel. Yeah, really super important tips there, and definitely not an easy thing to do. Our second question comes from Lindsay Jane. Jane's our second resident ambassador. She's asking, kind of about your thoughts. You talked a little about ICG, you talked about lymphoscintigraphy, but kind of what are your thoughts about MR, some of these other things we hear about MR, lymphangiography, ultrasound, for preoperative planning for your LVAs and such?
Yeah, no, that's also a really good question. I think we are limited by our direct fluorescent angiography for sure. It's only a certain depth. So MRL and ultrasound definitely give an opportunity to see structures that you may be able to manipulate significantly deeper than what we're able to see. And I do think it's quite a bit of promise. I think MRL is it's hard to implement in some ways because it's a timely exam. You need to get your radiologist on board. I think ultrasound's probably a little more versatile. I think we, as of somewhat late, and thanks to Ara actually, that we're trying to explore a little bit of that and trying to see the utility of being able to visualize these deeper structures. So definitely indocyanine green is not the end all be all, and I think these other modalities, as they get a little bit more honed in, will become probably the next wave of really isolating and really being more specific for our targets, particularly for bypass procedures.
Great, thanks, Dr. Patel. Our next question is from Daniel DeLuna. I'm going to boil this down a little bit. So basically, the treatment of microsurgical, supermicrosurgical treatment of lymphedema has a very high level of technical complexity of difficulty. So what are your recommendations, I guess, asking on for the resident level, trying to get some familiarity with these procedures and the overall training to kind of get started as residents in training in lymphedema treatment, surgical lymphedema treatment?
Yeah, so bypass procedures, speaking from personal experience, I kind of I taught myself a little bit how to do it, and it's a bit of a learning curve. These procedures used to take a long time when I first started, but I would say you have to arm yourself with the fundamentals of microsurgery. You have to understand what you need in addition to it, and meaning the super microsurgical equipment and the microscope, because last thing you want to do is be limited because you can't see the structures. So setting up that component's important, and if you have the fundamentals and understand the disease entity and who to do on, or what to do on who, and there are a lot of programs that you may not get the actual experience, or if you don't get it in your fellowship, if you're doing microsurgery fellowship, then you have to set it up in such a way and do your homework as if you were doing a new flap for the first time, which, you might go to the cadaver lab, or you rehearse it in your mind a few times. And then if you have the fundamentals down, you might struggle through it initially, but you got to kind of be persevere a little bit and just keep going. Because if you have the technical abilities, you can do it. Anyone can do it. It's just a matter of practice. It's the same as microsurgery, just a slightly smaller scale.
Great points. Thanks, Dr. Patel. We got a lot more questions coming in, so we'll try and get through these quickly. Rami Kantar asked a really good question. What have you found to be the most reliable metric or method for postoperative kind of quality of life assessments, the more subjective, how you're evaluating these outcomes in those surveys?
Yeah, so I would say I adopted the LYM QOL scale. It's validated, condition specific. It's got an upper extremity and lower extremity module. I think one's 20 questions, one's 22 questions. It's not too cumbersome. I know the ULL 27, which is for upper limb lymphedema, is fairly popular, but doesn't account for the lower extremity. Using kind of the more condition specific plus a general, SF 12 or 36 or whatever, those complement each other in some ways, and academically speaking are definitely modern in terms of being able to report. I know the folks that developed the BreastQ are well, at some point had talks of developing a LymphQ type of thing for lymphedema, which I'm sure will become validated and also would, be very valuable, just like the BreastQ has for breast reconstruction. But the LYM QOL, I think, is a very good instrument to use when you're assessing quality of life.
Great, thank you. Our next question is from Samir Halini, and this piggybacks a little bit off of what someone asked before, but he's basically asking how necessary is microsurgical training, i.e. fellowship, for building or developing a lymphedema program and kind of going along that career path.
I think a strong microsurgical background is important, because some of the technical nuances, not only for the bypass procedure, which I think can be learned by folks who have just an okay microsurgical experience, but lymph node transplantation is very nuanced, at least in the periphery. The omentum is becoming more and more popular, which we use quite a bit, and it doesn't really require that much kind of more nuanced microsurgical skill, to be honest. And so that can be kind of done by anyone. It's an omentum. It's just like the same omentum you use for a scalp. So you can definitely offer things. I think it is good, though, to have a comfort level, just because the bypass procedures do require some level of you kind of have to repetitiveness to get comfortable with it. And ideally, it's better to learn under someone else versus trying to figure it out on your own when you're out in practice.
Great, thanks, Dr. Patel. We have another question from Lindsay Janes, and this is something I was going to ask you, and I think you've written a paper on this as well. She's asking, what do you tell patients to expect post-operatively regarding the time course for improvement in symptoms after LVA and lymph node transfer? And I'd kind of expand upon that, just if you could comment a little bit on the patient counseling and setting expectations aspect of these procedures.
Yeah, so you're absolutely right. So if you go from the very beginning, I did look at this because when I came into practice, I had a very kind of obviously a very enthusiastic idea about lymphedema surgery and that it worked all the time and et cetera, et cetera. And what I was finding is that patients also were expecting that these surgeries would essentially cure lymphedema. And it was a little curious because there was a little bit of mismatch of expectations. I feel like as you start doing more and more, you realize you can't fix everything and that you can improve upon symptoms. And so you really have to bring the reality and expectations in line with one another, which involves a counseling component. And we actually did write that paper in PRS a number of years ago, setting the expectations. Post-operatively, LVA is very much like plumbing. I do feel as though you should see results fairly quickly. I tell the patients that I will evaluate the outcomes of that surgery at 3 months. And the reason is that when you do the surgery and you wrap the patient, you tell them to relax and keep their leg up, the leg's going to get smaller regardless. And only until they're back to their baseline, meaning back into their sleeve, back working, back doing everything, will they really be able to truthfully tell you if the surgery worked for them. And so I give that 3 months because first 3 weeks, the patients are wrapped completely because you can't really put a sleeve on top of fresh incisions. So we keep them wrapped and tell them to kind of, take it easy. And so 3 months for LVAs. For lymph node transfer, that it can take up to a while. I say we should about a year, sometimes even more. I've heard folks have had outcomes showing no outcome and then some positive outcome at 2 years. So it's variable, but I would say 1 year is a pretty good assessment. I tend to jump the gun a little bit and try to say, about 6 months to a year, I should see something. And mind you, most of the times I'm doing distal transfers, and for the most part, doing distal transfer versus proximal transfer seems to work a little bit quicker in providing some sort of outcome.
Thanks, Dr. Patel. And those are all really important points. And if for our kind of participants, if you haven't read that article in PRS, I'd highly recommend you do so. It really, I think, is important when you're definitely trying to consider the overall spectrum of care of these patients, aside from just the technical nuances as well. And Nelson Rodriguez kind of asks a question here that's a nice segue from what you were just mentioning. He's asking, do you prefer proximal or distal extremity sites for your lymph node transfers? And maybe you can kind of get into the why and your experience with that.
Yeah, typically the only time I'll go, well, there's two scenarios where I tend to go proximal. Number one is that there's scar from lymphadenectomy. And so the vast majority of time it'll be in the upper extremity. And so if there's a tight axilla, or I'm worried that there's some tightness there, there's scar present, the skin is of bad quality, or something it's causing somewhat of a scar tourniquet effect, then I will elect to release that scar and place the lymph nodes in that location. So that's number one. In the lower extremity, vast majority of the lower extremity lymphedema cases are from intrapelvic lymph node dissection. So there's no scars in the groin. It's all inside the belly. And obviously, we see our fair share of melanomas and extremity lymph node dissections like in the groin, but for the most part, they're in the pelvis. And so for the lower extremity, I'll tend to go distal. And distal, I tend to go mid-leg on the posterior tibial side. It gives me ability to use superficial veins, go into side of the posterior vessels, and still hide the flap. If you go too close to the ankle, you run into the problem of bulkiness, wearing clothes, socks, things like that. So that also plays in the quality of life. If your flaps are too bulky, you may have done somewhat more harm, because a lot of the patient's problems are just that: tightness around joints, wearing clothing, wearing their sleeves, all that other stuff. So you want to make sure the contour is reasonable as well. And so the other scenario where a proximal transfer in my practice is somewhat indicated, in particular the upper extremity, is if the swelling tends to be more proximal. And so there are a significant number of patients that will have swelling around the elbow and the arm with not much in the forearm. So I'll tend to go more proximal at that time, because I do feel there is some regional improvement when you place these lymph nodes around that area. And so those are the two scenarios for proximal, but for the most part, vast majority tend to be distal transfers.
Great. Thank you, Dr. Patel. And I want to thank kind of all our participants. We're having a lot of great questions here. I think we're going to take a few more, and then we'll wrap it up. A question here from Uday, and a tough one. Do you know, I guess, can you kind of explain some of the financial barriers to receive surgical lymphedema treatments? I know this varies from place to place, but maybe some things you've seen in your experience.
Yeah, no, there definitely is. And each insurance company has different policies for this. It's very regional. There have been now one or two statewide coverage policies that exist. But for the most part, the way I tackled it, because I did know about these coverage issues, is, I made it a point to meet with our various medical directors of the big five insurance companies when I came to LA, to just explain to them. And I do think there is a personal, component to that. If you meet these folks, show them what can happen and what you're able to do, and they, on the flip side, have patients requesting these surgeries, it becomes kind of you have an ally in some ways, as opposed to the traditional antagonistic environment that physicians and insurance companies have against each other. So you really, you have to work closely with them for that. But for sure, there are financial issues related to coverage. If I had to put a number on the lymphedema microsurgery cases that get covered versus not, my practice probably somewhere in the 85% range get covered, which is still pretty good. But we go through appeals and all that stuff for those folks who don't get coverage.
Great, thanks, Dr. Patel. It's a tough problem, one that, like you said, is constantly evolving. We have a question from Emily Long. What is the typical length of stay in your patients undergoing vascularized lymph node transfers? And do you use any ERAS protocols? Do you have any kind of standard post-op protocols for that? Obviously, differing a little bit between upper and lower extremity.
Yeah, so upper extremity patients who have a distal transfer. So, now in my practice, it's either omentum or it's the superficial groin lymph nodes. So for superficial groin lymph nodes, that is an overnight stay. Surgery time's usually in the about 3-hour range. If it's distal, proximal probably adds 45 minutes or more. Um, a drain in each site. They go to the floor. I do these at a hospital that they're comfortable without some ICU stay. Um, if they have an omentum, it's all about the abdominal discomfort and bowel return. For the upper extremity, these folks, I tell them for about a week they got to walk with their their forearm at the level of their heart. And so the omentum folks usually stay one night, sometimes 2 nights. For the lower extremity lymph node transfers, they stay in the hospital several days for the same reason we keep lower extremity free flaps there, for dangling reasons. So we start dangling at day 3 or 4, and then we give them a protocol at home depending on their home situation. But there isn't a ton of pain with these cases. As I said, the omentum is probably the only one that elicits some discomfort, just because it's intra-abdominal and we harvest it laparoscopically. So there isn't a ton of maybe advanced protocols because they don't go to the ICU. It's pretty minimal recovery, to be honest.
Great. Thanks, Dr. Patel. We're going to take, I think we'll take 2 more, even though, thank you all. These are all great questions and love to get to all of them. Daniel DeLuna is asking us, what are the minimum preoperative studies? You touched upon this briefly. A patient requires as part of the protocol. So kind of your standard, maybe nuts and bolts pre-op workup.
Yeah, so upper extremity for the most part is just a lymphoscintigraphy. I would say that there are plenty of surgeons that don't need that, which is also fine. And after having done quite a few of these cases, there's, for the most part, I can kind of tell if they're going to be bypass candidates versus they're going to need a lymph node transplant. But I do get that to evaluate the flow of their native lymphatic system, because it may provide value in the future for me to better stratify the patients. For the lower extremity, it's slightly different. We do still get the lymphoscintigraphy, but they all get a CT abdomen in the pelvis, because typically these patients have had intrapelvic cancers, and we have now found at least 3 cancers in the pelvis just with the preoperative workup, and have diagnosed it ourselves. The other part to the lower extremity is that it is prone to venous hypertension and insufficiency, so we are pretty thorough about either doing a venous insufficiency ultrasound or formal venograms. We have done a significant number of venograms, have actually found vein occlusions and other vein issues with that. I wouldn't say all the patients get venograms, but they definitely do get ultrasounds just to make sure their veins are working, because not only is venous edema probably the #1 cause of edema in the lower extremity, but also all of these procedures, we do really utilize the veins as our outflow for either the lymph node transplant or for the bypass procedure. So we got to make sure they work.
Great. I think let's take our last question here from Mohammed Ramadan. Says, fantastic presentation. Any tips or tricks on finding, this is, I think, an important aspect of it, good and functioning lymphatic channels for LVA? Are you doing that just by looking at it, any sophisticated tools, but really, trying to get that powerful LVA?
Yeah, no, I think the hunt is still on for a good technique. I think the most promising technology right now is probably this ultrasound technology, the essentially high definition ultrasound or high frequency ultrasound. I currently use indocyanine green and look at the quality of the flow. So I do essentially a dynamic lymphography for the most part, and really can tell where the lymphatics are going, and also which lymphatics are resulting in dermal backflow. And the presence of dermal backflow with a lymphatic leading up to it essentially indicates that pressure has gotten to the point where it's regurgitating into the subdermal lymphatics. And so that clues me in this analogy that I use with my patients, which is really fitting. And I use this highway and traffic analogy about creating detours off the highway before you hit the traffic jam. And that's very similarly what I try to do is find these highways where the lymphatic system is flowing, whether it's fast or slow, and see where it's backflowing. At what point does it backflow? And then I go just proximal to that to create a detour off of that lymphatic prior to that to decompress that backflow.
Great. Thank you very much. I think with that, we'll go ahead and wrap up our night. Thank you, Dr. Patel, for a great lecture and for taking time to join us.
Yeah. And if anyone has any questions offline, obviously we're short on time a little bit. You surely can email me. My email is ketan.patel@med.usc.edu. It is my university email, but we do check it. And if it's something I can't answer, I'm sure I can forward it on to someone who can.
Great. Thank you. And thank you to PRS, to Dr. Rorick, Aaron, Maddie, the whole team for making this possible. And we will see you all next year in 2022. Thank you. Good night.
Thank you.